Welcome to the Dental Handoff. I'm Dr. Kelly Tanner. Today I have with me again Dr. Mark Latta. It's kind of like Bill Nye, the science guy, if you guys remember Bill Nye, but it's like Mark Latta, the science guy. And I've had so much conversation recently with patients, with clinicians about fluoride versus hydroxyapatite products, toothpaste. Is it harmful? What's it doing? Does it work as well as, better than, should I replace it? Is it still good for me? Is it still bad for me? Conversation. So I brought Dr. Latta, who is, I say, your field expert in this, to talk to us. He is I don't know if you're a professor emeritus, Dr. Latta. If not, you should be at Creighton University in Nebraska. So Dr. Latta, thank you. Welcome back to our show.
Thanks, Kelly. It's good to see you. And so, as you say, I'm Bill Nye, the science guy. What I want to emphasize, I think, is that as a researcher and still a clinician, I'm a practodontist, but as a researcher, I'm also a theodontist. And so I think when we talk about all of these topics, whether it relates to fluoride, calcium, phosphate, other ions in over-the-counter products, consumer-based products, or professional products, I think there's some real solid evidence, really good evidence to talk about their effectiveness. And there's a growing body of evidence that I don't think that we've quite reached a threshold where we can say conclusively how some of these newer technologies actually work. And I can talk to you a little bit about the evolution of how some of these materials have been tried to be incorporated, not into what most consumers understand, over-the-counter toothpaste, mouth rinses, et cetera, but in dental restorative materials. And I think that's where some of the confusion might lie. And so I am still an active professor here at Creighton, and my emeritus status is as dean. I'm dean emeritus for my service as dean. So I think when we talk about fluoride, we need to, and I hate to put it this way because it sounds like it's ancient history, but we need to go back to the 1950s. When dental researchers at the time realized that people that lived in communities where there was naturally occurring fluoride in the water supply, these would have been areas like in the mountain west of Colorado and Wyoming, where there were high levels of fluoride in the well water or in the spring water that people were consuming. And that epidemiological studies showed that there was less decay, less tooth decay, less caries action in patients like that. Now, one of the downsides that was discovered back then is that in some of these communities where the fluoride concentration was quite high, there would be something called fluorosis, or the excessive amount of fluoride that was in the water supply caused a mottling or discoloration of the teeth. And even today, if children especially would consume too much fluoride or really bathe their mouths in their toothpaste and have fluoride, high levels of fluoride in contact with their teeth, we would still see these fluorosis spots, these white lesions most often is what we see. So there's a sweet spot of fluoride concentration in water supply that was discovered. And that's around, depending upon the time of the year, between 0.7 parts per million and 1.1, 1.2 parts per million in community water supplies. And those communities that incorporated that beginning in the late 1950s demonstrated over the next several decades a reduction in tooth decay of 50%, all other things being equal. So epidemiological studies will try to characterize for variables and things like that, but in aggregate, in tens of thousands, hundreds of thousands of assessments of patients in these fluoridated water communities, it became the single most effective public health tool for controlling what is a chronic epidemic, which is dental caries. Mm-hmm. So that's a little bit of the history of why we like fluoride. And then we see fluoride being incorporated significantly into toothpastes in those communities where fluoridation was not available, or in high-risk patients because of diet or other systemic situations. And so we see now fluoride in almost most over-the-counter oral health products. And this is based on the fact that solid evidence, strong research shows that fluoride exposure does minimize the effects of the bioburden, the biofilm, the plaque in a patient's mouth, particularly in people who have strep mutans, which is one of the etiologic microorganisms. Today now, because I think I would argue as a scientist, some misleading information that patients are demanding and asking that there be oral health products that are fluoride free. So let's talk about the chemistry a little bit. The way fluoride works.
Please, yes. You guys, his brain is so brilliant when it comes to this. Listen in.
Thank you. So the way fluoride works is we understand the disease process in caries. So tooth enamel is principally made up of hydroxyapatite, which is a crystal mineral. It's mostly inorganic. And, by its chemical name, it's this crystallized structure of calcium and phosphate that's in a crystal array with a hydroxy ion, an OH ion, which is part of a hydroxy chemical that's in the middle of this crystal. And this is a crystal that begins to dissolve at a pH of about 5.5. So in a patient's mouth, a normal patient's mouth, with a regular plaque, with consumption of food, this activates the metabolism of the bacteria. Bacteria produce acids that lowers the pH, that leads to the demineralization or the pulling out mostly of calcium from hydroxyapatite. Now, in most healthy people, once the food has been consumed, saliva flow brings back in a buffering capacity to a pH that is above 5.5, thereby stopping the demineralization. And in a healthy patient, calcium minerals from their saliva will be present on the surface of the tooth that will allow a chemical reaction to actually remineralize, to replace the calcium that got pulled out by the acid attack. Now, 5.5 is not a very low pH. And when we think about some of the dietary habits of people today, drinking, for example, highly carbonated energy drinks has a huge bioburden of carbohydrates, which feeds the bacteria, and they're very low in pH. They're very acidic. So they actually worsen this demineralization process. Now, when the pH starts to go back up in the presence of calcium and fluoride can get reintegrated into the hydroxyapatite crystal on the surface of enamel, creating what's called fluoroapatite. And fluoroapatite replaces the hydroxy, the OH, in the middle of the crystal, actually making a crystal that's smaller, tighter, to use a layperson's term. But the most important thing about that is the fluoroapatite dissolves at a lower pH. So if healthy human enamel dissolves at 5.5, fluoroapatite is more resistant to acid. It doesn't begin to dissolve until a pH of about 4.5. So what fluoride actually does is if it's incorporated into the tooth during this low pH, back to neutral pH cycle that we see in a physiologic environment in most patients, if fluoride's present during the remineralization, then this fluoroapatite is formed, and that is actually more resistant. Now, we can get more fluoride into the tooth. Fluoride is enhanced if there's calcium in the saliva or calcium in a varnish, for example, while this remineralization process is occurring. Now, where calcium is important is particularly for older patients, people that are on multiple medications where their salivary flow is reduced. the buffering capacity of their saliva because salivary flow has been decreased, then having calcium, not from their saliva, but from an outside exogenous treatment, is a good thing to enhance remineralization during this cycle of low pH and back to normal pH. So the evidence strongly shows, number one, fluoride significantly reduces the effects of demineralization as a result of the caries attack because of this pH phenomenon. It's not foolproof, but it does add a barrier to the acid attack. But we also know that in the presence of calcium, this remineralization process is really enhanced. And in fact, without calcium, it's really inhibited. So in a xerostomach patient with low salivary flow. So calcium now has been added into a variety of products. Now, in order for fluoride or calcium or any other ion, phosphate ions would be also part of the hydroxyapatite crystal, to be incorporated, they need to be in their ionic state. They need to be ions that can then react with the other fluoride moieties, the phosphate moieties, to form the enamel crystal, the hydroxyapatite fluoroapatite crystal. So some of the ingredients that are in toothpaste products, for example, they contain hydroxyapatite. Well, hydroxyapatite as a crystal isn't ionic, doesn't create calcium available in its ionic form. Therefore, there has to be a release of the calcium at the time of the remineralization, which is when the pH is returning back to neutral. So a toothpaste, a dentifrice, right now, the evidence for hydroxyapatite it being a significant source of calcium isn't at a really high level. Now, HA, hydroxyapatite, in a preparation might be better than nothing with a calcium source. But the difficulty with having hydroxyapatite is it's not easily producing calcium ions at a high level because the hydroxyapatite has to be dissolving in order to release the calcium. Now, where hydroxyapatite might be, and this is where, as I mentioned, over-the-counter products, dentifrices, even professionally applied products like a varnish might contain some hydroxyapatite in them, and they may have some value. Hydroxyapatite has been put into restorative materials or other crystals, glasses, bioglass would be one, where these glasses are put in, let's say, a Pitt and Fisher sealant or a composite, where they're locked into the filling or the sealant and very slowly release calcium. Now, there may be a benefit for that as well, even though the level of calcium is released at a much more slow level. Because if you think about a filling or a sealant, the surface of that sealant, when you get water uptake into the filling material or the resin matrix, the surface of that will absorb some water. And during a pH attack, the pH at that surface might actually cause the hydroxyapatite to release those calcium ions. But if you're thinking about a toothpaste or even a fluoride varnish that's, has a limited kind of lifespan on the teeth, in order for the HA to create that kind of environment where you have a high level of calcium, you have to have the hydroxyapatite dissolving. Now that sounds all right. So let's just put some soluble calcium or in a preparation. The problem with all of these preparations is most of them are water-based. And if you have fluoride and calcium in the same formula, they will precipitate into calcium fluoride, a crystal that is very insoluble. Now, the idea around professionally treated fluoride varnishes is these varnishes has a high level, 5% by weight of sodium fluoride, which is very soluble. The fluoride is released very quickly. But in the mouth, while the fluoride, if the varnish is applied during a remineralization step, the fluoride will go into the tooth. But the fluoride from the sodium fluoride varnish will also precipitate a crystal of calcium fluoride with the calcium in saliva, or if it's already in the preparation, creating crystal deposits on the surface of the enamel. This is how these varnishes desensitize, particularly on root surfaces. They deposit crystals that block dental tubules. But for caries prevention, they also leave calcium fluoride, tiny, and these are very small crystal deposits, on the tooth that under an acid attack will then themselves be a source for calcium and fluoride to be released in their ionic form so that they can then reintegrate into the tooth. So the chemistry of these materials, you have to, first of all, you have to have ionic minerals in order to be incorporated into the tooth. So back to one of your original points, is fluoride bad? Well, anything in too great a quantity is not good. But the levels of fluoride, particularly, for example, in a treatment done every 3 to 6 months with a 5% fluoride varnish, or in a dentifrice, or in a water supply, the long evidence going back 70 years is that fluoride at these therapeutic levels has a great benefit, and there's not evidence-based documentation of these levels of fluoride causing any adverse health effects at this point.
So there's two different types of fluoride that we're talking about too. The water source fluoride, because I think that it's important as we inform our patients and the public to talk about both, because you have those patients who come in, Dr. Latta, and say, I am against fluoride. I'm using hydroxyapatite or a non-fluoridated toothpaste. Well, what they don't realize is that the fluoride is most of the time in the water. And so I think there needs to be, when people say fluoride's bad, what kind of fluoride are you talking about? Is it fluoride in the water? Are they boycotting what they think that they're boycotting?
Well, that's true. And I don't know what the exact, I think about 70%, maybe it's a higher percentage than that of municipal water supplies are fluoridated. So certainly people that are on well water or people that live in agricultural remote areas may not get access to community water supplies that are fluoridated. But certainly people in urban and suburban areas most likely are getting this 0.7 to 1.1 parts per million of fluoride in their water supply. Now, it's interesting though, because the explosion of a variety of soft drinks, not just sodas, but energy drinks, sparkling waters, bottled waters, excuse me. People aren't, younger people especially are not getting in their drinking water those same levels of these materials, of the fluoride. So that's, I think is a component to this idea of really prevention that fluoride provides at these levels that is very inexpensive and tremendously effective.
Yeah, and the majority of the fluoride benefit, for the listeners who are listening who know the chemistry behind it, is of course while the tooth is in developmental stages. And so as we all age and our teeth have erupted, my guess, Mark, is that the benefit of the actual fluoride that's in the water is just so minute. It's such a small amount in the water supply itself. It couldn't take, I mean, the majority of the benefit is when you consume it and it goes into the developing tooth structure. But then what about the kind that's just in your water? Is that preventing decay?
Absolutely. There's no question. And as if you go back into the original work that was done, in the 50s and 60s, 1950s and 1960s, there's no question that the cause effect, that the reduction in tooth decay was a direct result of the fluoridation of community water supplies. But I think this is where some of the misinformation in our current day is an isolated incident of not a community water supply, but a naturally occurring amount of fluoride that's at a very high level can create some changes in bone metabolism, for example. But we're
Hmm.
talking about levels 10 to 50 times what's a therapeutic level in a community water supply. So, this was the fluorosis that we would see in teeth from people that lived in these kinds of communities. And there's some evidence, certainly, that in bone metabolism, that there would be some physiologic changes in the bone, because the fluoride is going to get incorporated into bone metabolism too, because the remineralization or the mineralization of bone driven by osteoclasts in that case might take into account if fluoride is systemic into the being modeled actually or being deposited in the bone structure. But at the levels that community water supplies are, there doesn't seem to be any evidence that that level of fluoride causes any problems.
Hmm. So what
So
about,
go ahead.
yeah, no, I was going to say that I know that our patients, and I think it was because of a specific marketing campaign, are coming in asking us, they're saying hydroxyapatite or nanohydroxyapatite toothpaste and materials. What's the best one to, well, they ask us because we're the chair side professionals, but they are thinking that it takes the place of fluoride. So what is your take on that? Because it's kind of hard to explain unless you look at it from an ionic level. It's not just cut and dry. It doesn't take the place of fluoride in toothpaste.
That is absolutely correct. And any dentifrice manufacturer, toothpaste manufacturer that incorporates HA hydroxyapatite into their product, if they say that there isn't a greater benefit in the presence of fluoride, they're not citing the evidence base. Now, consumers can make decisions based on their own judgment, and certainly having something with calcium in it is better than not if you're not going to have fluoride. But the question about nanohydroxyapatite is a little, there's not a high level of evidence yet to show clinically that nanohydroxyapatite in the presence of fluoride or without the presence of fluoride has any better effect on inhibition of decay than control groups. I think people are starting to do these studies. The nano has a particularly interesting theory that the nanoparticles are so small that in a toothpaste that they can be physically brushed on teeth, and the nanoparticles actually embedded into the spaces around the enamel rod crystal on the surface of enamel. And if that's true, and there may be an ionic affinity between the hydroxyapatite and the hydroxyapatite in the tooth and the hydroxyapatite from the dentifrice, that could create maybe a barrier or a resistance barrier, artificially created, a thin protective layer perhaps, to this acid attack, where when the acid attack comes, if this HA is on the surface, it's being dissolved instead of the underlying natural tooth structure.
Mm-hmm.
But that's based on the evidence, only a theory at this point that hasn't been well vetted and documented. So even some of those manufacturers are saying that our toothpaste has fluoride and hydroxyapatite in, and that gives you the best protection. Anybody that says at the levels that fluoride is in a dentifrice, that fluoride, that the hydroxyapatite or even calcium ions is as good as fluoride, there's not evidence for that yet. Together, calcium and fluoride seem to create an enhanced uptake in the tooth, better than just fluoride alone. But the fluoride has to be with a calcium ion that's bioavailable in its ionic form. And of course, hydroxyapatite isn't that soluble to be in its ionic form when it's applied to the tooth.
Yeah, it's hard to sometimes explain that science to our patients who are asking for it and sort of demanding it right now with I when they're saying when we're noticing curious lesions in their mouth, and they say it's, we're asking them, what's changed for you? Oh, okay, I've come off of a fluoridated toothpaste. Okay, because it's bad for you. I want to switch to something that's an alternative, and they're looking to us to say maybe hydroxyapatite works, but that's not true.
Well, it's not. There isn't evidence that says it's as or more effective without fluoride than a fluoride dentifrice. There is evidence that in combination, calcium and fluoride. Although this issue of hydroxyapatite being insoluble, it's really clear to us that the hydroxyapatite or the calcium source should provide for calcium in its ionic form. There's no question that with fluoride enhances remineralization. That is evidence-based. Whether hydroxyapatite provides enough calcium with fluoride to do that at a neutral pH, not under acid attack, that's yet to be seen. Because
so you brought up
that neutral, it's in that neutral pH that you get the remineralization, not the demineralization step.
So if you have even, so if a patient's using just a hydroxyapatite toothpaste and it's acidic, it's really not going to work.
Well, no, if there is an acid attack, the hydroxyapatite will dissolve a little bit at 5.5 and release the calcium. 5.5. Okay. But the longer effects, this calcium fluoride reservoir, if there's not fluoride there, you're not going to get the deposition of those crystals. Right. The longer effects aren't going to be there without fluoride, even with the hydroxyapatite dissolving. But it's really important to have the calcium at the time, particularly for a toothpaste, particularly for something that has a fairly low level that's applied regularly, where you really don't know at what stage of the pH cycle the mouth is in. So you really want to have the calcium at a neutral pH or the calcium in its ionic form so that it's available to be incorporated into the tooth in a remineralization kind of step. You want to saturate the plaque with calcium. And this is particularly important for, as I said earlier, for people that have lower salivary flow where their natural level of calcium that's bathing their teeth is lower.
Which is the majority of patients, because many of them are on medications that we have xerostomia, I would say, in probably 75% of our patients.
Sure.
All ages.
So the ideal, whether it's a professionally applied product, like a fluoride varnish or a dentifrice, is to put some of this calcium with fluoride at the site of remineralization. But again, the challenge is, and it's this reason people use hydroxyapatite, because the hydroxyapatite is so insoluble, you don't precipitate in the toothpaste tube the calcium fluoride, because you want the fluoride to be ionic. They put sodium fluoride in, it's very soluble. But so they put hydroxyapatite in, so there's not a lot of calcium ions in the toothpaste because it would precipitate in the tube. So you have to have an anhydrous, no water formula if you put calcium in its ionic form and fluoride in their ionic form, so they can't react and precipitate. And that's one of the reasons why you don't see toothpaste preparations like that. Now you have some preparations like MI paste, which has a very complicated molecule where you have fluoride on one end and calcium on the other that are connected to a milk protein. And the milk protein actually separates them from precipitating in the tube to calcium fluoride. And then in the mouth, that releases the two ionic forms so they can do their business. And that's the brilliance of that particular product called MI.
That's cool. That's really cool. Thank you. I could talk to you, as you know, for hours on this.
Well, forgive me for my lecture. You got me started and I just went. So.
Are you serious? It's been in almost every patient conversation that we've had, and there's not enough information out. So I just wanted to get this out to our listeners to say, okay, here's what the evidence says. And I was searching through PubMed and all the other journals, and there's not a straightforward answer as this does this or this doesn't do this. And so, Dr. Latta, thank you.
Well, and the chemistry of remineralization is complicated. I grossly oversimplified it a little bit, but it's still at a fundamental level. Fluoride can get incorporated into the tooth to decrease the solubility of the surface enamel. Fluorapatite is less soluble. That's one of the main mechanisms of fluoride. In the presence of calcium, that's enhanced. And those are two very strong evidence-based ideas. The effect of nanohydroxyapatite still to be determined. Its effectiveness at enhancing uptake and remineralization because of this solubility fact, it's in nanohydroxyapatite is basically at neutral pH and soluble, is still to be determined.
Thank you. All right, everyone. If you want to get in touch with Bill Nye, the science guy, also, we have to come up with a name for you, Dr. Latta, about everything. We'll have you back to talk to science up on other things. But thank you so much for being on the show again. If you guys want to get in touch with Dr. Latta, his information's in the show notes. And I look forward to seeing you in person again in June when I come there on some other research we're doing. And thank you for all you're doing, Dr. Latta.
Thanks, Kelly. Take care. Be well.
You too. To our listeners, you know what to do. Go on to Apple Podcast, give us a 5-star rating. Go on over to YouTube, like, subscribe, share to those you love. And don't forget to, as I mentioned, subscribe, because that lets the algorithm know that you like the content, and it also shares it with other people that you're connected with as well. Thank you for everyone that you're doing in our communities. I will see you well. Be well, my friends.